Okay, so once again, we'd like to welcome you all to our final pediatric session as part of our BIMA pediatric crash course. And we'd like to welcome our speaker, Dr. Shri Kumar, a pediatric reg from Kingston, I believe, who will be taking us through this session. So I'd like to pass it over to her and welcome you all.
Okay, you can call me Banu, by the way. Banu, Paediatric Reg in South London. I'm going to be doing my presentation on adolescent medicine, which is a huge topic. And it includes anything from mental health to eating disorders to pubertal development. And it's impossible to cover all of it in 1.5 hours. So I thought, rather than doing mental health and a bit of puberty, I thought I'll just do everything about puberty. And I'm happy to come back and do maybe another session on the other aspects of adolescent medicine. So today we're going to be looking at normal pubertal development. You guys probably know more about this than I do. And then also looking at precocious puberty, which is quite an important topic, and then delayed puberty. So they're all quite, they all linked, so it makes sense to do all of that together. And then we'll briefly talk about disorders of sexual development. And then I'll touch on pediatric history taking. I think this is a very important skill. And it's something that I wasn't taught in medical school. And I'm sure you guys know how to take good pediatric history, but I thought I'll share some tips because it comes up in exams. And it's, important to know, and it's very useful, especially if you do pediatrics in the future, which I hope you guys will do. And then I'll talk about this table that I have for developmental assessment. Again, this is what I use for my registrar exam, and this is quite concise. You can have a copy of this. It'll be quite helpful for exams. Cool. All right, we'll start. So I thought we'll start with some questions. Single best answers. Don't worry about getting it right, it's fine. You will know all the answers by the end. So yeah, just have a go. Let me know if you have any problems. So the first question, oh wow, people are already answering. So this is the tricky question, read carefully. So single best answer. So after what age is it normal to show signs of puberty in boys? Okay, we're getting some interesting answers. So about half of you are going for B, which is 10 years. And then the next popular answer is D. I'll give a couple more seconds. Okay, should we see what the right answer is? So it's D. Like I said, don't worry about getting it wrong. We'll go through this all. Next question. Let me just close the book. So the same question, but what age is it normal to show signs of puberty in girls? So have a think. Okay, most people are going for B. No one's going for D. Literally no one's going for D. That's great. Okay, most of you got it right. Well done, guys. Oops, what am I doing? I need to close this, I think, first. Oops. Okay, B, well done. Okay, next, what is the definition of talaki? I don't know if that's how you say it. So yeah, please ignore my pronunciations, but as long as you guys know what this means. Right, let's see what you guys think. Okay, so far the most popular answer is B, followed by A. Okay, great, well done, guys. Most of you got it right, so it is B, right. Let me close this and go to the next question. Okay, what about adrenarche? What is the definition of that? This is a bit of a tricky one. Think about what this means. I only know all these definitions because I looked it up before I started this presentation. I needed to remind myself what it meant. So don't worry if you get it wrong. Okay, so most people are going for B, followed by D. Let's see what the right answer is. Okay, so it is D. We'll go through this after. Right, next. Okay, so I thought I'll start with normal pubertal development. So what is puberty? So puberty is when you have development of secondary sexual characteristics and reproductive function, essentially. And in girls, the onset of puberty normally happens between the ages of 8 and 13, and in boys it's 9 and 14. So if you have a child who, let's say if you have a boy who has signs of puberty before the age of 9, that needs further investigation. That doesn't necessarily mean bloods and imaging, but you need to take a thorough history and do a detailed examination. We'll go on to precocious puberty later, so I won't say much now. And puberty is basically activated is when the hypothalamic pituitary axis is activated. I'm sure you guys are very familiar with this diagram. You probably know more about this than I do. So essentially you have, so the hypothalamus releases gonadotropin releasing hormone, which is basically a pulsatile secretion, and that works on gonadotropin cells in anterior pituitary gland, which produces luteinizing hormone and follicle stimulating hormone, and that works on both testes and ovaries. So the luteinizing hormone works on a particular type of cells in testes. Can anyone tell me what the cells are called? I have to think for a second, actually. Yeah, I think that's what it's called. So you can put them in the chat. Let me see if you can bring up the chat, or you can unmute and speak. Yay, well done. Yeah, I think it is Leydig cells, well done. And what about in ovaries? What kind of cells does it work on? So it works on a type of cell called T cells. Okay, so what that does is it produces, it works on, it stimulates the Leydig cells, and that produces testosterone, which basically causes testicular enlargement. FSH, that stimulates the ovaries, and LH and FSH works together to produce estradiol, essentially. Okay. Do you guys have any questions so far? If you have any questions, put them in the chat. Okay, I don't think there are any questions. Oops, sorry. Just to say, with the testosterone, so you have, so FSH can also contribute to that. So not just LH, FSH can also contribute to the production of testosterone, and how that differs from the testosterone produced by LH. So luteinizing hormone produces testosterone that causes enlargement of the testicles, whereas with FSH, that stimulates the development of so lengthening of the penis, facial hair, other secondary sexual characteristics, essentially. Okay, and then you obviously have the negative feedback, which causes, which works on gonadotropin releasing hormone that stops the production of LH and FSH. Okay, more questions. Right, so what is usually the first sign of, actually, before we do this, I just remembered, let me go back and do these definitions. Okay, so you guys got the first question, most of you got this right, I think. So talaki is breast development, and gonadotropin is when there's production of testosterone from the testes and estradiol from the ovaries. So these definitions are quite important to know, because they do come up a lot in exams, or even if you are doing pediatric placement, you see that in clinic letters or patient's notes. So it's really important to know what that means. Adrenal-K, so that essentially means awakening of the adrenal gland. That stimulates the production of androgen, which not only causes, development of the pubic and the axillary hair, but also body odor, and it, activates the sebaceous gland, so you can have acne. So that is all adrenal-K, okay? And the next one you can probably guess, puberty means appearance of pubic hair. Menarche, that's the first menstrual period. Okay, now we can go on to more questions. Right, so what is the first sign of pubertal development in girls? Okay, well done. So most of you got it right. Okay, I think almost everyone got it right. So it is breast bud, so breast development, essentially. Next question. Actually, no, I think more questions are coming up, but so this is quite an interesting diagram, and I think this explains it so well in just one, in one diagram. You can look at all the different aspects of secondary sexual characteristics and when it happens. So basically, like I said earlier, in females, most of the time, the first sign of puberty happens between the ages of 8 and 13. So the first sign is often breast development. Usually at the same time, you also have the stimulation of the ovaries, and you also have, in terms of the growth, they usually grow more around that time as well. And interestingly, about 15% of girls have pubic hair as the first onset of puberty. So not everyone will have breast development as a first sign. So that's just something to keep in mind. But I think for exam purposes, most of the cases would have breast development as the initial sign of puberty. And usually menarche happens around 2 to 2.5 years, or even 3 years after breast development, which you can see in this diagram. And this is quite good actually, because it tells you the mean for each characteristic. So you can see what I like to divide into two. So you can have adrenarche, which includes axillary hair, pubic hair, and then gonadarche, which includes breast development, because that comes from production of estradiol. So they usually overlap, but they're completely different processes. In females and males, normally you have adrenarche first, and then you have gonadarche first, and then adrenarche. But in males, sometimes you can have adrenarche before gonadarche. I don't know if that's a bit confusing, but what you need to remember is in females, breast budding is the first sign of pubertal development. I think that's all you essentially need to know at your level. And menarche happens 3 years after, okay? And this is what we call Tanner staging. So this is really good because it is a consistent way of measuring a child's progression of puberty, essentially. So you need to know the different stages. So stage 1, basically, no breast development, no signs of puberty. Stage 2 is when there's breast bud. So with this, you have to, it's not only inspection, you have to palpate, because feeling, adipose tissue can feel similar to breast tissue. So you have to palpate in order to do this accurately. And then the third stage is breast elevation, and you also have enlargement of the areola. Fourth is areolar mound, and I think that's above the contour of the breast, and then 5 is mature female breast. So normally these are very detailed stages, but I don't know, I like to keep things simple because I can't remember if it's not simple. So I broke it down into very, just a couple of words for each one. Hopefully this will be helpful for you guys. I don't know if you need to remember this, but it's just good to know the different stages. Okay. What about in boys? What is the first sign of pubertal development? Okay, that was quick. Oh no, that was the previous question. Okay, good. Most people are going for testicular enlargement. Well done, guys. It is testicular enlargement. Brownie points for anyone who tells me the size, like what is the number, and actually in terms of mil, what is the magic number? You can put in the chat if I figure out how to get the chat box back. Oops.
I think we've had someone say 2 ml and someone say 4 ml.
Okay, so it is 4 ml. And sorry, someone asked earlier, so the luteinizing hormone that acts on, in females, it acts on, I think, T cells. I can type it. It's probably the way I say it. Cool. Yeah, it is 4 ml. Well done. Okay, so this is the same as what you guys looked at before, but obviously this is for male. First thing is testicular enlargement, anything more than 4 mil essentially. And usually 6 months after that, you have lengthening of the penis. And around this time, the pubic hair also starts to develop, followed by facial and axillary hair. The growth spurt peaks later in males compared to females. Right, so this is the standard staging for male. Similar to the one for female, stage 1 means no puberty, okay? So don't be tricked by that. So stage 2 is when there's enlargement of the scrotum and the testes, but there's no enlargement of the penis in this stage. And it has to be, the testicular size has to be 4 mil or more, okay? And again, you need to examine, it can't just be inspection. Stage 3 is basically stage 2, but also enlargement of the penis. And then stage 4 is stage 3 to, and this darkening of the scrotum. And then 5 is adult genitalia. Okay, so we will now talk about precocious puberty. So what is precocious puberty? This is something that we quite often see in general pediatric outpatient clinic. Okay, so by definition, it is onset of secondary sexual characteristics before 8 in girls and 9 in boys. But you have to ask yourself, is it just one characteristic? Is it an isolated development, or are there other features of progression, pubertal progression? So it's really important to take a thorough history and do a detailed examination, because it changes your management plan, whether if it's an isolated development or if there are other features present. Okay, so by definition, true puberty is only when there is breast development in girls and testicular enlargement in boys. Okay, I will briefly talk about few conditions that we see in clinic which are completely benign. So we often get GP referrals, and these do not require any further investigation. So I'll just go through it really quickly. Breast budding in neonate, it is very common. It is because of maternal hormones, essentially. It's usually present for a few weeks, but it can last for a few months. And they have a discharge sometimes, and it's known as the witch's milk. Yeah, just thought that'll be interesting to share. The next one is pubic hair of infancy, which is basically associated with very small levels of DHEA, which is produced in, can actually someone tell me where it's produced? So that is DHEA. No? Yes, adrenal gland. Where about in the adrenal gland for, yes, adrenal cortex. Brownie points for anyone who tells me exactly where, yeah, well done. It's great, yeah. Well done, guys. See, I told you guys know more than me. I had to look this up. And this usually resolves by 2 years of age. Premature and talaki is when you have very small breast tissue, and that usually fluctuates over time. And again, this doesn't need any further investigation. That usually resolves by 3 years of age. Premature adrenarche is commonly seen in African Americans, and this doesn't involve rapid progression of puberty, so that's something you have to exclude. And most of the time, again, this doesn't need any further investigations. You could do a bone assessment, which we'll talk about later, just to exclude, significant causes of precocious puberty. So no, not precocious, delayed puberty. No, I mean precocious puberty. But anyway, so the point is that this doesn't need any further assessment if it doesn't involve any rapid progression of symptoms. Okay, if it's just premature adrenarche. Pubertal vaginal bleeding, so this could happen as a one-off episode, or it could be in patterns. And when you do blood tests, that usually show like pre-pubertal, the results are consistent with pre-pubertal, but you have to be very careful with something like that in pediatrics. You have to keep an open mind and include, safeguarding concerns, but that's a whole new topic, so I won't go into that. Just something to be aware of, because it's not always what you think sometimes. Next, okay, so what I like to do is, let's say you have a child who we think have precocious puberty. What are we going to do next? So I like to keep it simple. So I think about the causes, and when I do think about causes, I usually break it down. That just helps me understand it so much better. I usually do central and peripheral causes. Okay, so central is obviously gonadotrophin dependent, and what could cause this? So it's going to be something in the brain, right? So it could be a tumor. If it's a tumor, is it benign? Is it malignant? Or if it's like a congenital abnormality, such as hydrocephalus. And what does this cause? So in terms of blood tests, you need to know what you're looking for. This is what I like to do, because most of the time, if I don't know what I'm looking for, then I have results in front of me and I don't know what to do because I don't know what I'm looking for. So with central causes, you essentially have high luteinizing hormone, follicle stimulating hormone, because you have increased gonadotrophin releasing hormone. Okay. If it's a peripheral cause, which is gonadotrophin independent, again, this could be because of a tumor. So is it a testicular tumor? And is it benign or malignant? Or is it an adrenal tumor? Or is it part of a syndrome? So you have a couple of possible causes, okay? And then when you look at bloods, how is that going to help you narrow down what the possible causes could be? So if the luteinizing hormone and follicle stimulating hormone, that's low, and your sex hormones, estradiol and testosterone are high, it's likely to be a peripheral cause. However, in real life, it's not always clear cut. Yeah, but just something to keep in mind. Most of the time, you can tell if it's central or peripheral, but not all the time. Okay, so bit of change to the type of questions we've been doing. Let's say we have a 7-year-old girl who comes to general pediatric outpatient clinic with breast bud development. Okay, so if you guys want to type in the chat, what do you want to know in the history? Or you can unmute and speak. Yep, family history of early puberty, someone said, yep. Yep. So we'll do history first, and then we'll go on to examination. Yep, other signs of puberty, growth spurt, well done. Pubic hair, yep. Medication, so these are all good suggestions, guys. Keep it coming. Yep, yeah, we love birth history in pediatrics. Yep, yeah, past medical history, great. Okay, and then what about an examination? What examination do you want to do, and what do you expect to find? I mean, it's a bit of a tricky question, isn't it? Or like, as part of the examination, what would you do? Yes, so you need to do a systemic examination and palpate the breast tissue, yes. Weight, yeah, well done, weight, height, that's what I was going for. So it's so important to do that because that is part of examination. This is something that I sometimes forget in clinic and I always remember after. So yeah, so don't forget weight and height. Yes, we love Red Book. I thought I will quickly just go through pediatrics taking really briefly. You guys probably know this already. So presenting complaint, obviously what they presented with, and history of presenting complaint. So in this case, you've got someone with precocious puberty. So you need to know the timeline, you know, the onset and the sequence, how quickly did each stage progress, and birth history. So in terms of birth history, can you guys type in the chat, what would you include in the birth history? How do I get the chat again? Oh, there it is. I'm not good at this. Yep, so mode of delivery, birth weight, well done, yes. Yeah, gestation age, birth weight, yes. Antenatal, perinatal, postnatal, well done, yes. Exactly. I didn't think I have anything else to say, so yes. I usually just start with any concerns with antenatal scans, how were they born, normal delivery, if it's a C-section, why is it a C-section? Is it elective or emergency? Because usually there's a reason if it's elective. It could be a maternal reason, or it could be a neonatal reason. So you need to know why that is. And if it's an emergency section, ask why was it emergency? You know, that gives you crucial information about the neonate. You know, was the CTG abnormal? Those kind of things you need to know, okay? And how was, in terms of delivery, was he or she born in good condition? Did they need any help with breathing? Because if you've got a neonate who needed a lot of resuscitation and needed prolonged NICU stay, they could have delayed developmental. They could have delayed development. So again, that just helps you understand why they might have delayed development. Okay. And birth weight, definitely. And obviously the gestation, fine. And then developmental history, I usually keep it brief. I usually ask, do they have any concerns? I ask the parent, do they have any concerns? It depends. So if it's obviously a developmental, you know, history taking, then you focus on that. But otherwise, they come in with fever, a very quick question, do they have any developmental concerns? And that's okay. Past medical history, I usually also ask about any previous admissions, particularly if they come in with viral induced wheeze. You want to know if they've had any previous admissions for that. Do they need PICU, so that's pediatric ITU admissions, or HDU admissions, IV medications. So as in IV medications for viral induced disease, like were they seriously unwell, those kind of things. And medications, just, asking what medications they are on. Could that be related to precocious puberty or delayed puberty? And we like to ask about immunizations in pediatrics. Just a general question, just a quick question, are they up to date with all the immunizations? And then next, family history. So in this case, family history, any family history of precocious puberty, obviously you can't say it like that, as in you can't ask any family history of precocious puberty because parents will know what that means. So you ask the mother, how old was she when she started her periods? And then same with the father, how old was he? Okay. And then social history, always ask if they're known to social services. It can sometimes throw off parents, but I always say it's a routine question that we ask everyone, and you have to ask, especially if your history taking is for delayed puberty. We'll go on to that later, but you need to know if there are any social concerns, generally speaking. Okay, so that was just brief. I say brief, but I felt like that was a bit long. Anyway, going back to the case. So these things you guys already mentioned. So yes, the timeline, and don't forget to plot the height and weight. Okay, so also, has there been a recent growth spurt, or have they been following the same centile, or have they been jumping centiles? And then the other things we talked about, ask parents when they started puberty. So full examination, you need to do the tennis staging, you need to write tennis stage 1, 2, 3, okay? And then evidence of adrenal excess. So when you do the examination, look for any birthmarks, any features of Cushing syndrome. So yeah, so that's all very important. Right. Okay, so in terms of investigations, if, let's say, we have a child who has features of precocious puberty and we need to investigate further, we normally do an X-ray to assess bone age, and it looks at ossification pattern of small bones. You don't need to worry about this. The radiologist will do the report and they'll tell you. So essentially, they will say what the bone age is. Okay, so if it's, all you need to know is if it's more than 2 standard deviation of the child's age, that is very worrying. You need to do further investigation, okay, because that's not normal. You need to think about other causes, such as congenital adrenal hyperplasia, which is basically, it affects the production of androgen, aldosterone, and cortisol. It's a huge topic on its own, but essentially it can range anywhere from asymptomatic to life-threatening. And it is easier to see in girls, to diagnose in girls, because they present, or they're born with ambiguous genitalia. Okay, I won't go into too much because it is a huge topic, and trust me when I say that, it is not straightforward. So just leave it at that. But just so that you know, if the bone age assessment is more than 2 standard deviation of the child's age, that's not normal. Okay, I think that's what you need to know. And blood. So I always like to think, okay, why am I doing this blood test? So we do the routine blood test, full blood count, biochemistry, but someone with precocious puberty, you want to do further investigations. You want to do luteinizing hormone and follicle stimulating hormone. Again, that tells you whether it's a central or a peripheral cause, so that helps you narrow it down. Okay, and also you need to do estradiol and testosterone for reasons we talked about earlier. So if estradiol is high and LH and FSH levels are low, then that's likely to be peripheral. Okay, and if it's the other way around, it's likely to be central. And you need to do testosterone as well, because that could increase testosterone, could be result of tumor, testicular tumor in boys, which is very rare. That could still be possible. Or is an adrenal pathology. So that will tell you if the testosterone is high, you need to think about, is there an adrenal pathology, which is why you need to send DHEA. Okay. And what do you do if the blood results are abnormal? So if they're abnormal and you are not still entirely sure, or you think it could be a central or peripheral cause, that will really help you decide the next investigation, essentially. If you're thinking of a central cause, you wanted an MRI brain, so to exclude a central mass, essentially. Or if it's a peripheral cause, you want to do a pelvic ultrasound scan. Are there any ovarian cysts? You can also look at the, the ovarian follicles. And in boys, are there any evidence of testicular tumor? And if you're suspecting adrenal tumor, you want to do either abdominal ultrasound or CT. And if that's still normal and you're still suspecting a peripheral cause, you can do an MRI of the abdomen. So in summary, when it comes to precocious puberty, if you have someone in clinic who has precocious puberty, bloods are suggestive of that, and clinical features, examination findings, if they're all suggestive of that, you want to speak to endocrine early. And the reason for that is because in terms of the height, this will have precocious puberty. Early puberty has a significant impact on the adult height, so you need to investigate early, but it doesn't mean that you need to do everything there and then in clinic. You can take your time, speak to endocrine, and formulate a plan. You need to follow up the patient regularly. In a district general, you still need to follow up the patient, but they might need tertiary level follow-up as well. So it's thinking about, do they need tertiary input? Okay, and you need to list all your investigations, everything you've done. Okay, and you need to put your examination findings, and you need to put Tanner staging, all of that. Okay, so moving on to delayed puberty. Right, which one of the following is a sign of delayed puberty in boys? Okay, so most people are going for C. Great, well done. Yep, you guys are on it. Yes, it is C, well done. What about in girls? I think I know the answer. Yeah, I think I know the answer. Okay, well done. So most of you went for C, which is the right answer. Great. Okay, so what is the definition of delayed puberty? In boys, it is defined as no testicular enlargement by age 14, essentially, or if they take more than 5 years to complete adult genital growth. Whereas in girls, it is no breast development by age 13, or if they have no menstruation by age 16, or if they take more than 3 years between first breast growth and first menstrual period, also known as menarche. Okay. Okay, so which one of these causes delayed puberty? Yay. Well done. Well done, guys. Yes, it's all of above. Well done. That was a tricky question, but you got it right. Okay, so the point is there are so many causes of delayed puberty. You don't need to know everything. It's impossible for anyone to know everything. What's important is knowing that there are so many causes, and you can break it down into either, again, central, peripheral causes, or you can break it down into medical, non-medical, or you can do systems, whatever works for you. Find a system that works for you and stick to it, okay? I'll go through some of the common causes. Constitutional growth delay is the most common cause of delayed puberty. Can someone tell me what the difference between constitutional growth delay and familial short stature is? I think this could be potentially exam question. You can put in the chat. You can figure out where it is. Don't put this in the feedback, okay? I don't know how to navigate. Someone put, they will be shorter as the, so is that for familial short stature or? And yeah, constitutional growth delay, they will eventually catch up. Yes, yes. Constitution is a comparison of parents. So constitutional growth delay is the most common cause, and they are often called late bloomers because they often they have delayed puberty compared to their peers, and they may have delayed pubertal growth spurt as well. And it's not because their parents are short, but it's because the parents, either the mother or father, had delayed puberty themselves. So that is essentially the difference. Whereas in familial short stature, the parents are short. Okay. I hope that makes sense. And then I thought we could break it down into other causes such as chronic illness. Is there an underlying medical condition? Does the child have chronic, sorry, so someone said, could you explain? So familial short stature is when the parents are short. It doesn't necessarily mean that they have delayed puberty, okay? Whereas constitutional growth delay, the parents are not necessarily short. It's more that they have delayed puberty, and it's often inherited because their parents probably had, or most of the cases, they would have had delayed puberty themselves. Does that make sense? Okay, good. Yeah, so in terms of chronic conditions, so chronic kidney disease, for example, especially if it's stage 4 or 5, you will often have prolonged hospital admissions. You know, you need regular dialysis, so you'll be in and out of hospital a lot, and you will also have a lot of medication that you'll be taking. So it's just to keep an open mind and to think about all these different causes, okay? So just thinking, could this be causing delayed puberty, okay? Rather than an organic, as in rather than a sort of, what I'm trying to say is rather than problem with the actual secretion of testosterone or estradiol, okay? Is it caused by another factor? Okay, so you need to keep an open mind. And this is why a good history taking is very essential. Malnutrition, again, is this because of lack of calories, because of psychosocial deprivation, or is it because of an eating disorder, which is completely different, and that includes anorexia and bulimia? Or is it because of malabsorption, such as celiac? So you can categorize further and think about, you know, possible causes that way. Or is it part of a genetic or a chromosomal condition? Or is there a disorder of sexual development, of which congenital adrenal hyperplasia is the most common one, okay? You don't need to remember all of this, but just be aware that there are so many causes, and you can think of a couple. Okay, I'll briefly talk about this because I think this is very complicated and I don't want to confuse you guys, and I don't think you need to know much about this at your level. And we already I think 50 minutes into the presentation, so it's, you know, impossible to take everything in. So don't worry if this is a bit too much. Just take in what you can. All right. So disorders of sexual development is essentially a group of congenital conditions. Congenital means that you're born with it. associated with abnormal development of both internal and external genital structures. Again, there are so many causes. You don't need to know all of them or even most of them. I don't know most of them. But this is just to tell you that you can, again, divide into categories, and this will help you understand not just, it won't just help you remember it, but also it will help you understand the pathway, or like help you understand why this causes sexual disorder of sexual development. Okay, so you can have 46XX DSD, which is essentially virilized females, and the most common one is congenital adrenal hyperplasia. Okay, I know this has come up so many times, but like I explained before, it is associated with abnormal function of the enzymes that is responsible for the production of androgen, cortisol, and aldosterone. Okay, so you can have a wide range of symptoms, and it can be asymptomatic. It might be a late diagnosis, or it could be present at birth. All right, but it can be life-threatening, especially in neonates. If it's in a female and they present with ambiguous genitalia, they could have something called salt losing crisis, which can cause an adrenal crisis essentially. So you need to treat immediately. But otherwise, it is usually diagnosed late. Okay. Or is it because of an XY DSD that is usually associated with abnormal testicular differentiation? Or is there a chromosomal or a genetic condition, such as Turner syndrome and Klinefelter? I think this will probably be more useful for you guys, because in pediatrics, there are so many syndromes. I don't know a lot of them, but these I feel like you should know because they do come up in exams. It has come up in pediatric exams. Can't remember medical school exams because it was a long time ago, but I'm sure you need to know these syndromes. Okay, so we can quickly go through those. Right, I'll show you an image. So on the next slide. Should I show you this first? Oh no, what did I do? Okay, now you know the answer. How do I, hold on. Okay, have a look at this image and going back to the question. So what characteristic, well, the first question is what syndrome is this? For that, I need to go back. Minimize? No, I can't minimize. Okay, so what syndrome does this image represent? To know where the poll's gone. So because I minimized it. Oops. Right, can we please bring up the poll again?
The poll's on. Do you want me to restart it?
Oh, sorry. Yes, please.
Yeah.
Okay. Probably me accidentally closing it. Yeah, cool. What syndrome is this? Okay, interesting. Oh, yes, yes. Sorry, I was looking at the wrong alphabet. Yeah, well done, guys. Yes, that's right. It is Turner syndrome. Some of you went for E, although there's no E, but that's fine. Most of you went for D, so well done. What can you see in this photo? Like, what is the characteristic feature of this syndrome? That comes up all the time in exams. I'm sure examiners love this characteristic feature. That they always put this up. You can put it in the chat. Yeah, well done. Yes. Yes. I know there are a lot of words. You don't need to know everything because that's impossible and that's a bit insane. You just need to know the common characteristic features that help you distinguish this from a different syndrome. And for Turner syndrome, it's mostly like low hairline, I think in exams they usually say widely spaced nipples, webbed neck, or no menstruation, amenorrhea. These are the classic words that often come up. I can send the presentation around, so you'll have a copy of this. Okay, let's do a case for a change. So you've got a 15-year-old boy coming to your clinic, okay? He's got multiple delayed secondary sexual characteristics, and that includes reduced facial and axillary hair and small male genitalia. This is a GP referral. This is what you get. Your patient's coming in 5 minutes. So what questions do you want to ask them? Put in the chat. Yep, family history. Oh yeah, Andy said it wasn't symmetrical. Well done. So they have short neck essentially, but yeah, it should be symmetrical. I was going to say, what is TY, but that's thank you. Thank you. Okay. So in terms of the history of presenting complaint, what else do you want to ask? So the GP's given you some information. He said there are some delayed secondary sexual characteristics. So you've got the boy in front of you now. And he has a parent with him as well. So what would you like to ask in terms of pubertal development? What else do you want to ask about? Yeah, timeline, yep, and growth spurt. Has there been a recent growth spurt? Yeah, everything we talked about earlier. Okay. And what about an examination? Yep, general and testicle examination, well done. And you have to not only inspect, remember to palpate, okay? And what else do we want to include in the examination apart from general and testicle examination? What did we say last time? We won't forget. What is that one thing I keep forgetting in my clinic? Yes, height and weight, well done. Okay, so he tells you that he has mild dyslexia and difficulty paying attention. He's also had developmental delay and only learned to walk at 16 months of age. So that's what you would get as part of the developmental assessment, and mild dyslexia, that would come into past medical history. So just to remember, it might not all just be related to the puberty. You have to think about possible developmental delay as well, which he does have. And you remember the height. The height is on the 99th centile. On examination, you can see that he has lack of facial hair, gynecomastia. What is gynecomastia, guys? This is probably too easy for you. Yes, well done. And Tanner stage 2. Okay, this is a tricky question. What is Tanner stage 2 for male? Let's see who remembers it. Let's see who is paying attention. Yes, for male. Well done. You remember the number. Good. Okay, that is the most important thing. Okay, so now that you have all the information, are you thinking of a particular syndrome? Can you suggest any? No, what am I doing? Okay. Yes, well done, guys. Klinefelter syndrome. Again, you don't need to know everything on this diagram. So main things I would say: tall stature. They could have difficulty concentrating, maybe mildly impaired IQ, but this is very subjective. Gynecomastia is the classic one, okay? So that's associated with Klinefelter. Small testes, okay? So just remember those important ones. You don't need to know everything. And this is the table that I mentioned earlier. This is all I learned for my clinicals. I don't know if this is something that you have to do for your exam, you need to know, but if you do, this is a really good table because it's very concise. I know it doesn't look concise, but compared to other tables, this is very good. So yeah, I'll send it around if you want this. This is all yours. I think that is it. Do you guys have any questions?